Good morning. My name is Ernest Dole, and I'm the clinical pharmacist for the UNM Pain Consultation and Treatment Center, and also an associate clinical professor at the UNM College of Pharmacy. And thank you so much for working with me on this lecture and allowing me to tape it, because I have a chance to be in Norway at the time of the lecture and celebrate my birthday on June 21st with the summer solstice at the top of the world. So the learning objectives for this are to apply what we talk about and then be able to assess appropriate patients for chronic opiate therapy and identify strategies on how to deal with patients who may or may not be using their opiates appropriately. So when looking at the cases I want to present, and what I want to do is illustrate a point. So I'm going to run through 4 cases. The first one is a 50-year-old woman, proven back disease or degenerative disc disease by MRI. She gets a prescription for hydrocodone 500, 4 times a day, and within 5 days she's out. So she calls 2 days early, says they're not strong enough. At the next case is a gentleman you've been seeing for years, mid-50s, proven back disease, hydrocodone 500. He has a family gathering, and after the gathering he goes to take his pain medicines and he realizes that they're gone. In the third case, and this is actually someone who we all sort of cringe at when we have to see him, is a patient that comes in with notes in the chart as far as lost and stolen prescriptions, always wanting early refills. You see him, and 2 weeks after the first meeting, he calls and says his hydrocodone 500 4 times a day was stolen. And then the last case is a 74-year-old man with lung cancer on hospice. You're taking care of his pain medicines, one of which is hydrocodone 500 4 times a day. He calls up for his refills and mentions them also that he needs his morphine elixir refilled. When you mention you don't fill his morphine elixir, he hangs up, and then you run a board of pharmacy prescription monitoring report on him and realize he's been getting morphine from providers all over town. So there's similarities in all these people. And what I want to point out is that if you notice what the similarities were, it's hydrocodone 500 4 times a day. So the first person was actually my wife, who stood up one Sunday, her disc went out, and I'm sure I would have found her sooner if there wasn't a Bronco game on. However, there was, and so that's been a source of contention. And the last person was actually somebody who also presents an easy sort of trap to walk into, in that he's somebody on hospice, and I think once somebody has cancer, we sort of have the attitude that, well, they're going to die, so we'll give them everything they want. And so this was somebody I actually fought for him to get brand name OxyContin. And later on, I find out that he's burning me. And I walked right into the situation and the mindset of, well, he's having cancer, so let's give him whatever he wants. So again, when you prescribe opiates, it's a balancing act. And the Joint Commission has said that pain is a 5th vital sign and that it needs to be treated appropriately. However, you look at other things and other public health issues, that Morbidity and Mortality Weekly has come out with statistics back in 2011 and have since revised these in March of 2013. And unless you've been living under a rock or you've been unaware somehow, you probably realize that New Mexico was #1 up until March in accidental overdoses due to pain medicine. Other things that have to be balanced are like the patient's demands, in that I think oftentimes patients feel that their pain should be relieved completely, which really, past a certain age doesn't happen. I'm in my, actually by the time of this lecture, I'm in my late 50s. And, you get up and you hurt. That's just part of the deal. And patients wanting to have all their pain taken away isn't a realistic goal. I think part of our job is educating patients on what is real and what isn't real. Also, patients, I think, feel that there's a magic bullet out there that takes care of their pain. And for some patients, it does tend to be opiates. But the problem is, in the long run, opiates usually cause as many problems as they solve. And the other thing that I've had discussions with patients of is after I find out that something's inappropriate, either their drug screen or their Board of Pharmacy report, and then they sort of own up to it after it's been presented to them, and you say, well, I need to change things because it's not safe for you to continue using these opiates, then you get the discussion of, what, I'm being now penalized for being honest. And that's not true. So there's the patient's agenda that has to be balanced. And then lastly, the provider's agenda. In that, one, as providers, we do not want to contribute to a problem. We want to make sure we take care of people's pain, but at the same time not enable either someone to supplement their income with the medications we're using, or two, that we don't contribute to a problem that's already there, either a substance abuse problem or an addiction problem. So the other thing as providers is the fear of having the DEA knock on our door. Now, realistically, the DEA has a hard job to do, but they're also not known for their tolerance or for their sense of humor, and they have guns. And the last thing we want to do is be talking to a DEA agent. So putting all these together, the next thing is, okay, great. How do we treat people in chronic pain? And the guiding principles in treating anybody with any medication is that it's based on efficacy, safety, and evidence-based medicine. And for me, when I look at opiates, I actually use corticosteroids as a similar analogy, in that corticosteroids usually take away anybody's pain. So do opiates. Corticosteroids usually mask it, but cure nothing. Same thing with opiates. And opiates, I should have said before. And if you use corticosteroids long enough, you're going to get in trouble with other systematic effects, and the same thing with opiates. And the interesting thing is when they found corticosteroids back in the late 50s and early 60s, they really thought they had cured everything. And it wasn't until things started to go wrong that they realized that there was a hypothalamus pituitary adrenal axis that didn't exist. And there's probably is an axis that involves endorphins, norepinephrine, dopamine that we haven't figured out yet. So, evidence-based medicine is that. The efficacy for opiates and chronic non-cancer pain, it depends on who you look at. The interesting thing is that there really has not been a consensus yet. And if you look at the Chow guidelines in 2009, which is what most internal medicine and family practice folks talk about, they do say that opiates are an appropriate category of medication to treat chronic pain in carefully selected patients. If you look at the Society for Interventional Physicians, they basically say there's no place for anything except tramadol, and that's also on shaky ground. So the efficacy data for opiates really isn't there. If you look at the safety data for opiates, which then talks about things like how we've already talked about the increase in overdoses, and if you look at the lines, and I'm sure most of you have probably seen this discussion before, but if you look at the prescriptions for opiates and the overdose deaths from prescription medication, mostly driven by opiates, you are going to see the same line. And so it's hard to get away from the fact that as we have become more liberal prescribing opiates, more people have died. The other thing is that opiates tend to decrease testosterone levels by decreasing luteinizing hormone. And when you have low testosterone levels, you tend to become depressed, be it male or female, and then you drop your serotonin and norepinephrine centrally, you're in more pain. If you look at the other things that opiates do as far as systematic issues, you have decreases in thyroid, and opiates can also affect the immune system. So there's 4 types of opiate receptors: mu, kappa, delta, sigma. And how different opiates work for analgesia primarily depends on how well they bind to the mu receptor. And there's different places in the body that opiate receptors are found. And I'm going to breeze over this one, mostly to save time for other subjects. But again, the mu receptors mostly are responsible for opiate and analgesia, mostly responsible for the euphoria effect of opiates. So if you have a partial agonist-antagonist for that receptor, you can have differing effects. Now, moving on and looking at where the receptors are. Again, I just want to show this mostly to sort of hammer home the point that opiate receptors are ubiquitous throughout the body, much like steroid receptors are ubiquitous throughout the body. And my point being that in many ways, it may have been naive of us to sort of buy into the fact that there's no maximum dose of opiates, when clearly anything that has receptors throughout the body are going to have effects throughout the body. Now, looking at opiates and chronic pain, again, for neuropathic pain, not a lot of good data. Patients I have with primarily neuropathic pain that say hydrocodone or oxycodone works for their pain, I honestly don't know if it really works for their pain per se as much as it does as just making the world look better so their pain doesn't bother them as much. When you look at back pain, there may be a place for chronic opiate therapy and chronic back pain, and so, as being someone who's blown their L4 disc, acutely there's more of a role. Past 6 months, it really doesn't look like they add to efficacy that much. If you look at osteoarthritis, personally I think they've definitely out of place, because I got a new left knee in October of 2012, and in the months preceding that, from June to October, both my knees were bone on bone, with my left one being much worse. And had it not been for some opiate medication, by the end of the day, I'm pretty much sure I would have killed somebody in those 4 months that I had before the surgery. And again, in other chronic diseases, there may be a place, but it's becoming more and more questionable. So, looking at this algorithm, there's no way that you can memorize everything there. And the point is not to memorize it, but the point is to realize if you superimpose this algorithm on any other chronic disease, be it diabetes, be it hypertension, be it lipids, you're going to get something similar, to where you obviously want to start out with a diagnosis. You want to have proof that the diagnosis exists. And then you go from the simplest plan to the most complicated plan. So while this looks complicated, if you think about it, opiates for chronic pain really look similar for any other chronic medicine for any other chronic disease. Now, the other thing is that there's certain requirements that have been mandated by the New Mexico Board of Medicine for treating chronic pain, which is why I'm sure all you are here. I know I can be entertaining, but I'm not near as entertaining as this room being full. And I'm sure that a lot of you have the simple agenda that I need to get those hours for CE that are mandated by the board. And so the board's mandated other things that need to be in place when you treat chronic pain. There needs to be a diagnosis. Again, when you treat hypertension, when you treat lipids, when you treat diabetes, you want a diagnosis. The interesting thing for me is that the American Association of Family Practice has come out and said that no opiate should be prescribed unless there's hard data. And so we all turn to the MRI. But the MRI is notorious for not having correlation between the degree of damage shown by the MRI and also the level of pain. There needs to be in place things like patient substance agreements. There needs to be in contracts. There needs to be in place urine drug screens. So a lot of what we're going to talk about is mandated by the Board of Medicine. But the other part of it is a lot of what we're going to talk about is what you do with any other chronic disease. Not only has the Board of Medicine had requirements, the FDA has released what they call REMS guidelines, and REMS stands for Risk and Education Mitigating Strategies. So what these entail is that there's suggestions, and these suggestions are much like suggestions for using a parachute when you jump out of a plane. In the sense that once they were released, it's not that you really have to do them, but if you don't do them and something goes wrong, you can always be held responsible. So the REMS guidelines also put in place that they want a controlled substance agreement. Not so much a contract anymore, but an agreement. That there's urine tox screens and there's screening tools so that you can help select appropriate patients for chronic opiate therapy. So managing and monitoring chronic opiates. Again, some of this is going to be a little bit redundant, but you want a diagnosis. You want criteria for selecting the most appropriate patients, and you want to be guided by the 4 A's of opiate therapy, or really any analgesic therapy. Is there any analgesia or adequate analgesia after using this medication? Are they able to do more or function more? Are there adverse events, and is there presence or absence of aberrant behavior? The other thing is that you want to do pre and post assessments. So once you try an opiate medication, you want to follow up and make sure you had an adequate response. And to be honest, I always sort of use as a rule of thumb that I'm willing to increase the opiate dose a couple of times. And after that, I'll always discuss with the patient that if this was a blood pressure medicine, diabetes, cholesterol medicine, we didn't get a response, I'd say we're on the wrong medicine and it's time to quit. You want to review the pain diagnosis and see if it still fits. The interesting thing I found is after one pain sort of gets taken care of appropriately, then another one may rise to the surface. And I think what's really important is that you systemize the data process and you systemize how you make decisions, because as was shown on one of the slides earlier, one addict affects 7 to 10 people, which means everybody has been touched by this, and usually in negative ways. So the more that you can systematize how you approach this, how you gather data, and make it a data-driven decision, I think the less your personal feelings get in the way. And the other thing is, again, document, document, document. Because I think, as long as things are documented and your thought process is clear and transparent, there shouldn't be any problems. So screening tools. Here's an example of some screening tools. Oh, I'm sorry, let me back up. So we've now got to the point to where we're going to use an opiate. So we've gone through all the processes of, is an opiate appropriate, is there a diagnosis, etc., and is the patient an appropriate choice for opiate therapy. So what's low, moderate, moderately high? So low therapy is usually 5 to 30 milligrams of morphine a day or its equivalent. Moderate therapy is up to 74 milligrams. Moderately high is up to 100 milligrams. And high is up to 100 or 120 milligrams. Now, one of the reasons 100 to 120 was chosen as a cutoff is that there is data to show that once you get past 100 milligrams a day of morphine, which incidentally is 80 milligrams of oxycodone, the accidental overdose rate shoots up by a factor of 8 to 9. And as far as very high doses of opiates, very rarely is that needed. Again, I think there's only so hard you can hit a nail. And using an analogy of a bus, that if you're on a bus and every seat is taken, you can't put more people on that bus. Being that if every receptor is full of an opiate, giving more opiates isn't going to help. Looking at opiate analgesic doses, and sometimes that's confusing too. But I always start as saying with chronic opiate therapy, 1 milligram of morphine is the starting point. So 1 milligram of morphine then equals 1 milligram of hydrocodone. So hydrocodone and morphine have the same potency. Then moving on, oxycodone is 1.5 times as potent. So 1.5 milligrams of oxycodone equals 1 milligram of morphine. And when you look at it in sort of a practical way, that makes sense because you have 30 milligram tablets of MS-Contin, you have 20 milligram tablets of OxyContin. You have 60 milligrams of MS-Contin, you have 40 milligrams of OxyContin, and so on. Now, the next one is usually Opana or oxymorphone, and that's the more active metabolite of oxycodone, which is an active parent compound. And so oxymorphone or Opana is twice that of oxycodone, or 3 milligrams. And then methadone we'll talk about in the next slide. And then also looking at fentanyl, a way that I remember it is if you're on a fentanyl patch of 200 or of 100 micrograms per hour, that's 2,400 micrograms of morphine a day, or 2,400 micrograms of fentanyl a day, or 240 milligrams of morphine. So, now going to the one that's the hardest one, which is methadone. And remember, in methadone, there is no cross-tolerance with traditional mu opioids. So when you look at the next slide, what you're going to see is sort of a range. So if you're on morphine up to 99 to 100 milligrams a day, the conversion is going to be roughly 3 milligrams of morphine equals 1 milligram of methadone. If you're on from 100 milligrams on up to, off the top of my head, and since the slide's behind me, I can't remember what the next one is, as far as, but it's 5 to 1, morphine to methadone. And what you're going to see is that the methadone becomes more and more potent the higher doses of morphine you have. And that is, again, because there's no cross-tolerance. So no matter how people may be very, very tolerant to morphine, oxycodone, hydrocodone, but they have no cross-tolerance to methadone. Now, other thing just to mention quickly on this slide is this is for morphine going to methadone. It doesn't really hold for methadone going to morphine. And there is a website that you can use that actually shows some figures for this, and that's globalrph.com. And I think it's www.globalrph.com. And that actually has some information in it for going from methadone to morphine. Okay, so I've beat that to death. Now, you've gone through all the thought processes up. There's a diagnosis of, say, low back pain. There's a proven diagnosis of knee osteoarthritis. You've done the screening test. They scored appropriately. You've kept them at a decent range of opiates. And the next problem is my favorite saying that the road to hell is paved with good intentions. So when you've done all you could and something bad still happens, physical dependence and tolerance are not addiction. And I think the important point is a lot of times people don't use these terms appropriately, and they're very, very, very emotionally charged terms. So physical dependence and tolerance happens with anything. So it's not just opiates, but it's clonidine has a withdrawal syndrome associated to it. Paxil, SSRIs have a withdrawal syndrome associated to it. Physical dependence is a physical adaptation. Tolerance is a physical adaptation. And one of the exercises I use with my patients And granted, they're usually patients of the World War II era who don't want to get addicted or become a hophead. I'll ask them to do some role playing, and I'll say, okay, let's pretend that you have diabetes and I put you on insulin. Now, you're now physically dependent on the insulin for proper body functions. Your body will become tolerant to the insulin because of repeated exposure. Are you addicted to the insulin? And in my world, no, because addiction is a behavior disorder and not a physical dependence disorder. So when you look at addiction, again, I think that is a behavior disorder, and it's manifested by the lack of control or by compulsive use. And my favorite definition of addiction is repeated behavior in the face of negative circumstances. So it can be drugs, it can be alcohol, it can be gambling, it can be sex, it can be anything that you do repeatedly that you have no control over despite something bad happened to you. Pseudo-addiction, to me, is sort of the other side of the coin of addiction. Usually with pseudo-addiction, once the pain's taken care of, people stop asking for more pain medicine. With addiction, the saying's true that one's too many and 1,000 isn't enough. And a great example of pseudo-addiction was the example of my wife that we did earlier. Whereas once her pain was taken care of, one, she didn't ask for any more pain medicine. She really didn't use the pain medicine. Withdrawal, hyperalgesia, opiate withdrawal, again, I'm sure we've all seen patients with it. It's like having the flu, only the worst case of the flu for a while. And then opiate hyperalgesia. And that is actually where your brain has a set point for pain. And if we pass that by giving more and more and more and more opiates, your brain then wants to bring everything back to its homeostatic set point and then begins to synthesize more pain receptors so that it can do that. So it then becomes a situation where more doesn't work, and in fact more causes more pain. And it may be also that after chronic exposure, opiates cause inflammation in the glial cells of the nerve, causing more pain. And then the one that, again, is most uncomfortable to deal with is aberrant medication-related behavior. So when you look at the next slide, you're going to see that the most important predictive factors for aberrant behavior are a prior history of substance abuse. Not rocket science there. Now, again, I'll not to tell you too much of my personal history because it's not that interesting, but since I have a God with a very twisted sense of humor, I'm actually in recovery and 24 years in January with my drug of choice being opiates. So you can see the irony of this. But again, a past history of substance abuse, if somebody's there, it's really hard unless you're working hard and working a program not to go back to it. That doesn't mean that people with a past history, one, don't get pain medication, and two, it matters how long ago that was. If you have a family with a history of substance abuse, whether it's related or it's just that it's nurture and you grew up in a chaotic household and what you saw was basically coping with stress by taking something, and that's what you learned, it's unclear. But it is clear that a family history of substance abuse is a risk factor for developing related medication behavior. And the other one is decreasing age. And it's interesting because in, say, the World War II Korean era vets, you really don't see, you see more of a concern of becoming addicted, where in the younger age group, you see a concern for not getting enough opiates. So the other things that can happen, and looking at the next slide, are screening for risk. And again, it's mandated by the Board of Medicine, and it's also quote-unquote suggested by the FDA REMS guidelines. And there's a number of screening tools that you can use. At UNM, in our pain clinic, we use what's called the SOAP-R. Part of the reason being that we're doing research with the University of Washington, and that's what they use. The one I actually like is the ORT, or opioid risk tool. And the reason is it has only 5 questions. But the other thing is it asks a question about sexual abuse. And I think the presence of PTSD is a huge, huge risk factor for aberrant-related medication behavior. And aberrant behavior and PTSD and chronic pain, when you look at the courses of the disease, almost parallel each other, and it almost seems like PTSD and chronic pain sort of ramp up each other's systems and make the symptoms of each disease a little worse. The CAGE, I'm sure you're all familiar with, more for alcohol. And again, by the FDA REMS guidelines, by the Board of Medicine, you need to use a screening tool. Now, here's my caution with screening tools. And I'll mention this a little bit more in one of the other slides, but I think that we tend to get a false sense of confidence, whereas it's like, well, they got a low score on the SOAP-R, and then you get burned by a patient, and you're going, well, how could they do that? They scored lower on the SOAP-R. And I think sometimes scoring low on these tests, we sort of let our guard down. So on the next slide, you're going to see that a list of aberrant behavior. And again, some of these are worse than others. Obviously, forging a prescription is much worse than increasing the dose on your own. Stealing the medicine is much worse than an early refill. Robbing to get the money for the medicine is much worse than increasing the dose on their own. So there's a continuum of behaviors. And again, they all indicate, however, that there's a lack of control over the opiate medication. And you are going to see patients who, despite a couple of conversations, are going to increase the dose on their own and then run out early. So early refills, medications from other than medical sources, that includes family members and friends, and a continuum of behaviors that are red flags that things aren't working as well as we planned. So other things to look at is the fact that clinical judgment alone really doesn't do a good job of discovering aberrant behavior. And part of the reason is that, to be honest, with those screening tools, when I was practicing, which again was a long time ago and actually people weren't as sophisticated, but I can tell you, I would not tell you the truth on any of those screening tools. Remember, if I'm somebody who is using the medication inappropriately, my job is to get that prescription. And people can be very, very good. And I think that one of the things we fail to realize is you will not meet a population more goal-directed than somebody who wants that opiate prescription. You will not meet a population that's more charming and intelligent. So their job is to get that medication from you. And so, however, I think if you approach it like any other chronic disease, like, okay, did they screen low or high on the screening tools? That's a watch factor. Do you have data showing that they're getting opiates filled somewhere else? So clinical judgment in and of itself doesn't always work. So what you want to do is have this as a data-driven process. And so that data-driven process is, again, looking at screening tools, so that you have a higher index of suspicion, but you should always have one. Going back to the principle of universal precautions, looking at urine drug screens, are they appropriate or inappropriate, and looking at pharmacy monitor, prescription monitor treatment programs. Also looking at pharmacy records, it's perfectly appropriate to call a pharmacy like Walmart or an independent one like Sam's and go, when was the last time they filled this? And looking at chart notes, and if they light up saying patient has a history of early refills, that data is in there for a reason. But the whole point is, if you make it a data-driven process, much like when you refill lisinopril, insulin, lovastatin, That's data-driven. This is data-driven. I think you tend, hopefully, to remove your personal bias out of it. So, substance agreements. Again, mandated by the Board of Medicine, suggested by the FDA REMS thing, guidelines, not things. And really, this is an option for you to discuss with the patient the risks of chronic opiate therapy. And for some patients, it truly may be the fact that their testosterone drops to nothing may be a reason that they don't want to continue it. So it's an opportunity for you to educate the patient about the risks of chronic opiate medication. Again, if somebody's been on opiates for 10 years, they may not be that open to discussing that. But if it's somebody who newly is going to be placed on an opiate therapy for possibly long term, you bring up the fact that opiates interfere with thyroid, immune system, endocrine system, constipation. They may not jump on the opiate bandwagon as quickly as they would have been before. The other thing is with agreements that there's conflicting data that they work well or not. And my personal opinion, which really doesn't mean a lot because it's mandated by law, is that I think controlled substance agreements sometimes give us a false sense of confidence. In that I've heard, provider after provider say, they signed a contract. How could they do this? Again, if I'm somebody who wants the opiate prescription, I'm going to say anything you want me to say and sign anything you want me to sign. So you still, even when they sign an agreement, you need to have a high index of suspicion. Drug testing. And drug testing is great because it's more complicated and subtle than I think people think. And so, again, mandated by the Board of Medicine, suggested by the FDA REMS guidelines. However, the other thing is, urine drug screens in and of themselves don't really, you miss a lot of aberrant behavior. And so it is put together with the PMP reports, it is put together with clinical judgment, but this is a valuable tool in detecting aberrant behavior. In one study, a large percentage of patients that later showed up for aberrant behavior did not have inappropriate urine drug screens. So, again, sort of going to the fact that a patient who wants the opiate prescription is incredibly goal-directed, and people being people and fairly intelligent are going to find ways to get around the rules. So when you do an opiate an opiate screen or a urine drug screen, one of the things you want to look at is the test that you're using going to test for the medication you're looking for? And an example of this is one time early in my career doing this, a patient swore up and down that they were taking their methadone. Just swore up and down. And I'm like, well, look, it's negative. It shows right here in black and white you're not taking it. And so later that week, I went to the pain clinic. It wasn't here. It was at my other job, my previous job. I went to the pain clinic staffing, and everybody looked at me and said, the test you used doesn't test for methadone. And after I thanked them for telling me the wrong test to do, I went back, did it again, looked for methadone. Methadone was there. The other thing with urine drug screens is to make sure that you ask the patient, when did they last take the medication? So if they're taking Percocet and they're taking 2 a day, and the last time they took it was a day ago, it may show up as negative, which is appropriate. If they're on OxyContin, 40 milligrams 3 times a day, and it shows up negative, I think then there's another discussion. So the other thing is that make sure you're aware of the possibility for false positives and false negatives. And one of the things that I think where you can get into trouble with easily is if you have a screening test, that's by immunoassay. And there's one for opiates, which is codeine, hydrocodone, morphine, hydromorphone, and one for oxycodone, which is oxycodone and oxymorphone. And if it's a screening test, those may cross-react. And when you get a screening test back that says positive for opiates and could be this, 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 and this, to me that does me no good. And I think you need to be aware of the metabolites of opiates and also get a confirmatory test so that you know the specific compound you're dealing with. So that if somebody is taking oxycodone and there shows up for hydromorphone and hydrocodone, that's appropriate. So moving on, and I'm going to pick up the pace because what I don't want to do is keep you here longer than necessary. So this looks at the metabolites of different opiates. So hydrocodone goes to hydromorphone via the 2D6 and cytochrome P450 enzyme. Hydrocodone and hydromorphone in the same sample, definitely appropriate. Oxycodone going to oxymorphone via the cytochrome 2D6, perfectly appropriate. It does raise concern if you've got oxycodone at a very high level, no oxymorphone, because they may have just been able to shave some of the tablet into the urine, and that's why there's no metabolite. Another thing to think of is the presence of codeine and morphine together may be a red flag for heroin. And there is a test that you can use called 6-MAM, 6-monoacetyl morphine, which is only produced by heroin. The Board of Pharmacy reports are great and a godsend. And the Board of Pharmacy here in New Mexico is working with Colorado to finalize an agreement so that we could share data for border towns. We've already got one with Arizona. Texas, being Texas, is really not cooperating. And while I have concerns as sort of a big brother paranoia, this really does help because you can look for people getting opiate prescriptions from different providers, and you're not relying on the kindness of people to call you up and say, hey, your patient's seeing me for pain medication too. This is looking basically really at questions looking for addiction. Was put in more for completeness sake because we are not addiction specialists, nor are we policemen. But it is good to be familiar with what people are looking for so that if you come across it, maybe a light bulb goes on. Again, this is looking at the diagnosis for addiction and really put in for completeness sake and as a point for when do you send somebody to an addiction specialist. And I think the next slide also is a continuation of that. So addressing aberrant behavior. So this is a discussion you hate, right? So again, you've done everything right. They have a diagnosis, they have an MRI, you're doing the right doses, and either a tox screen shows up inappropriate, or you run a PMP report, which again is mandated by the Board of Medicine and also the REMS guidelines, and you find out they're going to 2 or 3 different people. One of the ways I think that I deal with it is increase the frequency of drug screens. Have them come in mid-month, do a pill count. Limit refills or no refills, and instead of giving a month, give 2 weeks. I think there's a much, much different psychological reaction to getting 180 oxycodone, and it looks infinite for the first 3 weeks, and then somebody's back's against the wall versus getting 90. It's a much smaller bottle, it's a much smaller amount, or even getting a week's supply. You can transition them to another medication, like tramadol, and really what I have done, and the most success I have had, is center the discussion around safety. And I've been talking all about treating chronic pain like any other chronic disease, so here's a point. If somebody had an upper GI bleed from naproxen, and they begged you for a naproxen prescription because their knees are bad and this is the only thing that took care of it, you would not give them another naproxen prescription. The same thing holds here. If somebody's doing extra opiates, you would not give them another opiate prescription. And there's some controversy about, do you give one and give them a month? Do you say that's it and give them clonidine? The point being, safety is the predominant and really the concern. So that when you tell somebody, I cannot safely continue to give you this medication because of what you're doing, you're not calling somebody a drug addict. You're not making a judgment on their personal lifestyle. But what you are saying is, we can't continue doing this from a safety response. And weaning and tapering opioids, usually, I've done it many, many different ways. Most people can tolerate a 10 to 25% decrease per week, and without much discomfort, for want of a better word. Again, the point is, if somebody's doing something that they shouldn't do, and you give them a weaning prescription, and it lasts a month, and you say, okay, here you go, do it this way, and they take everything you gave them in a week and overdosed, you're still on the hook for that. So there's a real gray area in how to address it. And I don't know what the best area is, but you can give people clonidine, 0.1 milligram tablet, 2 to 4 times a day to decrease the norepinephrine flood coming out of the brain because it's unhappy that the opiates are gone. The other thing to think about when you're weaning people from opiates is very rarely is that fatal. They may wish they would die, but very rarely is it fatal. Clonidine can help. Tizanidine as a muscle relaxer can help. They both work by a central alpha agonist method, so you need to be careful of blood pressure. The thing you don't want to do is treat the anxiety from opiate withdrawal with a benzodiazepine. So what I am saying and what I'm not saying, or do's and don'ts, emphasize that this medicine does help take the edge off the pain. Don't say, or don't treat exclusively by the pain scale, even though we're trying to make a subjective response into objective data, and don't say and continue to reinforce that you're not going to take all the pain away. But your goal is to reduce the pain so they can do more in their life. Do start low and go slow. Don't use more and more immediate release opiates at a higher dose. And again, a lot of that slides common sense. And do consider a long-acting opiate if, say, somebody has long periods of time when they can't take an immediate release opiate, such as going to sleep or work, or if you're using, higher and higher doses of immediate release opioids like we talked about on the last slide. The point to consider, though, is that long-acting opiates really have shown no more efficacy over shorter-acting opiates over time. So, what I'm not saying, I am not saying don't use opiates. They're a medication. It's a neutral chemical, much like lovastatin, insulin, etc. It's us that sort of gives the drug power by bringing our biases into it. Opiates are not bad drugs. Yes, they're dangerous, but insulin kills people. They go hypoglycemic, they drive, they hit somebody. Warfarin kills people. Antibiotics are the only medications we use that change the environment within us and without us, so now there's bugs that really are not happy when we use antibiotics. So there's many, many, many drugs we use that have a downside, and opiates are one of them. And so, again, what I did and what I wanted to sort of drive home was the point of thinking when you prescribe opiates. So what I did when I was at a conference supposedly paying attention and actually in the back screwing around with my friend, I came up with an acronym called THINK, and then I filled in the words later. But hopefully by using this helps memorize some points, and it helps drive home think when you prescribe opiates. And again, I think the common tools we use in chronic medication management go right out the window with opiates. So the T stands for, bring the data. The T stands for taking in with you the data that you have when you go in to talk to somebody. And think about what you have and what objective you have that you can use in the discussion. When you go to talk with somebody, especially if there's aberrant behavior involved, have the data in hand. And what I'll do with patients is, I'll go, come up and look at this drug screen with me. This is what your test shows. It's not that I'm saying it's good or bad, it's just this is what it is. Or bring the PMP report with you. And I always ask people, is anybody else giving you pain medication? And if they say no, I'll ask them again. And sometimes I'll ask 3 times. You think by the 3rd time people would tumble to it, but again, they've got a lot invested into the medication, so they may never, until forced to, really tell the whole story. Using your intuition can be an incredibly double-edged sword. Because if you only use your intuition, you can make a bad decision. However, if you use your intuition coupled with urine drug screens, board reports, chart notes, it can help. And again, there's something called the SARS syndrome, like something ain't right syndrome. And, if you get a bad feeling, follow it up, but don't use it as the only thing that you're going to use for a decision. No is a valid answer. Remember, our primary concern is patient safety. And if somebody is unable to control their opiate dose, or if they're doing other things with their medicine, like it's not there and it's supposed to be and maybe selling it, which puts them at a high-risk behavior, saying no is a valid answer. To those of you with children, you've done that constantly when they were 2, 16, 34 maybe. You survive the tantrum. So no is a valid answer because our job, first and foremost, is to do no harm. And then K, know the rules and regulations. Again, the Board of Medicine put down some rules for prescribing chronic opiates and chronic non-cancer pain. But when I look at those, they're really no different than you would use for any other chronic disease. Do you have a diagnosis? Is there data to support it? Do you have a goal in mind? If the medication doesn't work, do you have an exit strategy? So K is basically for know the rules for where you're practicing. And lastly, in conclusion, again, opiates are a double-edged sword, as with any chronic medication. Really, if anything's going to have an upside, there's got to be a downside somewhere. Realize that aberrant behavior is a continuum of behaviors, and as shown on one of the slides, addiction, alcoholism is 10% incidence in the general population, so for every 10 people you see, 1 person's going to have their life changed when you give them the medication. Doesn't mean they can't have it, but again, realize that aberrant behavior is part of the deal of using opiates. Much like bleeding's part of the deal of using warfarin. And so again, think about what you're doing. Try and make it a systematic decision versus a gut level decision. Try not to bring your biases involved and realize what you bring to the table. And I think the more you treat this as any other chronic disease and treat the opiates as any other chronic medication and don't give them power, then I think chances are you're going to do fine. If you look at the rules laid down by the Board of Medicine, again, I don't think they're out of line. And with that, thank you, and thank you for allowing me to do this via taping. I did put an inordinate amount of references in this handout, just because, 1, I wanted you to know I really worked on this, and 2, I wanted you to have a fairly complete list of references in case you had questions. If you do have questions, please feel free to email me at edole, like pineapple, E-D-O-L-E, at salud.unm.edu. So that's edole at salud.unm.edu. And give me a couple days to get back to you. Also, I have the attention span of a 5-year-old with ADD, and there's usually 2 or 3 people talking to me at once at work. So if I don't get back to you in a couple days, please feel free to continue to email me. And thank you for allowing me to sit in this morning.